I think we couldn't find a venue, but I wanted to give this class physically. But however, we move. Several issues. I was informed that you were inquiring about your continuous assessment test, whether there will be one or there will be two. So you will have two continuous assessment tests. As you're aware, this semester you are learning pathology 3 and pathology 4, and therefore these are cut specific for pathology 3 and cut specific for pathology 4. So for pathology 3, you will be examined on pathology of your cardiovascular system, respiratory system, gastrointestinal system, and hepatobiliary system. So you'll be tested from your lecture on atherosclerosis up to your last lecture, which will be, I think, on gallbladder. Let me check your schedule. So that will be pathology 1. Pathology 3, sorry. Your terms confuse me. So from the lecture you had on 10th of November up to the 15th of December, so next week on Monday, that encompasses pathology 3, and that is what you will be tested on in the first cut. Then the second cut will be on pathology 4, which encompasses lectures between what will be taught from 17th of December, which starts with genitourinary system, up to 26th of January 2026, God willing, disorders of skin. So all lectures covered between that is what will be covered in our pathology 4. So it usually includes genitourinary pathology, endocrine pathology, central nervous system, bone, joint, and skin. So that is pathology 4. So they'll all be different cuts. So even in your exam, you will have two exams, paper 1 and paper 2. So paper 1 will be pathology of your cardiovascular system, respiratory system, gastrointestinal system, and hepatobiliary system. And then paper 2 will be pathology of your genitourinary system, central nervous system, endocrine pathology, disorders of bone and joints, and skin. So that will be your second paper. I hope that's clear. The other thing I was told is you're requesting to have the exam in January and not next week. That is okay. You'll just guide us on which day you will be available starting next year. Then we'll organize how to administer the cut. I hope you are okay up to that point. You can respond in the chat if that is understandable. If not, you can ask your question. Okay, so let's go through our lecture for today. We'll be looking at hepatitis, and then we'll also look at liver infection. So hepatitis, as the name suggests, means inflammation of the liver. And inflammation of the liver can be caused by several things, as we will see, but it can also occur due to liver infections, which we are going to look at in detail. Before we look at the liver hepatitis, I always like to go through the normal anatomy. And why this is important is so that when we refer to different areas of inflammation, you have an idea from what we have discussed. So you know that the normal adult liver weighs between 1400 to 1600 grams. From your anatomy, you know that the liver has a dual blood supply, with the portal vein providing 60 to 70% of the hepatic blood flow and the hepatic artery supplying the remaining 30 to 40%. Um, and that's why when you ingest substances, they will still get to the liver because they'll be absorbed in the intestine. Then through the portal vein, they will they will pass through the liver. Then, of course, oxygen and all the other nutrients will be supplied by the hepatic artery, which will branch off from the aorta. Other than that, the hepatic microarchitecture is usually divided into lobules, which are centered on a terminal tributary of the hepatic vein and are demarcated by portal tracts at their periphery. And why this is important is because when we refer to inflammation around the liver, we're going to talk about certain conditions where you'll have inflammation centered around the hepatic vein, while others will cause inflammation that is centered around the portal tracts. So it's important to understand the structure of the liver. So these lobules are often drawn as hexagonal structure, though in humans the shapes are far more variable, but the hexagonal structure is for us to be able to understand the various parts of the liver and pathology as it as it ensues. So the hepatocytes in the vicinity of the terminal hepatic vein are called centrilobular hepatocytes. They are in the center of the lobule, and those that are in the portal tract are in the periportal region. So we'll see that in certain types of inflammation, it will be centrilobular mainly, and others will be periportal. So it's important to understand that. So these zones differ in metabolic activities and also in susceptibility to hepatic injury. So this is just a diagrammatic representation of how the different lobules look like. So in the center, you can see the central vein. So CV is the central vein. And then on the corners is now where you have these portal tracts. And in this region, you have a branch of your portal vein, you have a branch of your hepatic artery, and these regions also have the branch of the bile ducts that now go and coalesce together. And then this lobule is divided into acini, and this acini has zones. So we have zone 3, zone 2, and zone 1. Why is this important? If, for example, your injurious agent is, let's say, hypoxia, for example, you can see that the areas around the central vein will be mostly affected because by the time blood with oxygen flows from the hepatic artery all the way to the central vein, this will take time. So these areas are susceptible to like hypoxic injury and the rest. Then for, let's say, chemical substance that you've ingested. So they were taken up in the intestines, and therefore they're coming to the liver through the portal vein. So the first part of the cell to be affected are the cells that are around this portal tract. So that's usually very important. So depending on what the injurious agent is, you'll have more injury either in zone 1, zone 2, or in zone 3. So that's why it's important to see the structure of the liver. So this is just a histological segment. And here, of course, you can see histologically, they don't form a perfect lobule, hexagonal structure, but you can see you have a central vein in the middle, and then you have this portal area with a portal vein, hepatic artery, and bile duct. Also, in terms of fibrosis, we'll talk about portal to central, central to central. So you can have this central vein pathology moving from one central vein to another central vein in another lobule, or from the portal area to the central vein. So we'll be referring to portal to central, portal to portal, central to central. So those are the terms that we will use. So hepatocytes are usually organized into anastomosing sheets or plates extending from the portal tracts to the terminal hepatic veins. So between the trabecular plates of hepatocytes are vascular sinusoids, and this sinusoids is where blood traverses and exits into the terminal hepatic vein. I think I have an image. So you have these hepatocytes, and then in between them, you have these sinusoids. So you have within these sinusoids, you have blood flowing from the hepatic vein, from the portal, from the hepatic artery, from the portal vein, and then they all flowing towards the central vein. Remember, all this blood still has to get to the hepatic vein, which then drains into the inferior vena cava, and then it will find its way to the heart. So hepatocytes are bathed by well-mixed portal venous blood on one side and hepatic arterial blood on the other. So they're able to get the nutrients that are coming from the GIT, or the chemicals that are coming from the GIT, and also blood and all the oxygen and nutrients that are coming from the hepatic artery. So the sinusoids are usually lined by a fenestrated endothelium that overlies a perisinusoidal space called the space of Disse, into which abundant hepatocyte macrovilli protrude, and therefore they are able now to get all the nutrients and substances that is in the sinusoids. So attached to the luminal face of the sinusoids, you also find Kupffer cells. These are hepatic macrophages, which are important in various pathologies, as you will see. So another specialized cell type found in the space of Disse is the hepatic stellate cell, and this cell has a role in the storage of vitamin A. But this hepatic stellate cell is also the key cell that you see in fibrosis that occurs in the liver, leading to liver cirrhosis. So between abutting hepatocytes are also bile canaliculi, channels that are usually 1 to 2 micrometers in diameter, and these channels will drain successively into the intralobular canals of Herring, then into the periportal bile ductules, and then finally this will drain into the terminal bile ducts within the portal tract, and then this is what will go join with the cystic duct from the gallbladder to form your common bile duct. So this is a diagrammatic representation. So you have your hepatocytes, and then you have your sinusoids. So blood is moving from your portal vein on one side and your hepatic artery on the other side, and then all this will drain into the central vein. Then between the hepatocytes and your sinusoids, we talked about the space of Disse, which also has this area. You have your Kupffer cells, which are your hepatic macrophages, and then you also have your stellate cells, which we've said are important in storage of vitamin A. And I've also said this will be very important when you'll be discussing liver cirrhosis, because it starts from activation of this stellate cell. So from your physiology, you know that the liver has the enormous task of maintaining the body's metabolic homeostasis. And these tasks include the processing of dietary amino acids, carbohydrates, lipids, and vitamins. The liver is also important in the synthesis of serum proteins, especially albumin, and it is also important in detoxification and excretion into bile of endogenous waste products and xenobiotics, like the drugs that you consume. So, as a result of all these metabolic activities, the liver therefore becomes susceptible to metabolic, toxic, microbial, and circulatory insults, because it's the area that will process most of these chemicals. So, disease processes in the liver can be primary or secondary. Primary meaning that they're affecting the liver itself, or secondary meaning that there's an abnormality somewhere else, but it has effect on the liver. So, the functional reserve and regenerative capacity of the liver usually masks to some extent the clinical impact of early liver damage. Remember, um, the lecture in general pathology, where we were talking about tissue and tissue healing and repair, and we talked about the liver being a stable tissue with a very high capacity to regenerate, and that regenerative capacity is what enables it to be able to withstand a lot of the injurious agents that it is exposed to. However, with a progression of diffuse disease or disruption of circulation or bile flow, the consequences of deranged liver function become severe and even life threatening. So it can be able to accommodate, but if this becomes excessive, then that liver now will undergo damage. So when that happens, then the liver becomes inflamed. And inflammation of the liver is what we refer to as hepatitis. And this hepatitis can be acute or chronic. So it can be an acute exposure, or it can be something that is going on over a period of time, what we call chronic. So this inflammation is usually associated with an influx of acute or chronic inflammatory cells, as you learned in acute and chronic inflammation in your previous semester. Inflammation can be preceded by necrosis. Of course, remember the lecture on cell injury, where we said, depending on which injurious agent the cells in the liver are exposed to, then these cells will die via necrosis or apoptosis. And when they die of necrosis, the contents of the cell are able to be discharged, and they go into the extracellular space where they are noticed as foreign, and therefore they will trigger an immune response leading to inflammation. So most of the time, your necrosis is what will precede inflammation, where you have cell death, or you can have inflammation that leads to necrosis, especially if the first insult is, let's say, like an infection. So you end up having inflammation as the response to that infection, and then the inflammation causes damage to cells, leading to necrosis. So inflammation may be limited to the portal tracts, but may also spill over into the parenchyma. So remember the hepatic lobule, as I've shown you. Certain substances, foreign bodies, and some organisms, and even some drugs may incite a granulomatous inflammation. So you don't get the usual chronic inflammation, but you get a granulomatous inflammation. For example, if you have infections with Mycobacterium tuberculosis in the liver, it is going to give you a granulomatous inflammation. So for acute hepatitis, this is hepatitis where you have acute active hepatocellular damage, and then you have necrosis caused often by viral infections, autoimmune disease, or adverse drug reactions. And histologically, a patient who's having acute hepatitis, they will have lobular disarray. So that diagrammatic representation I've shown you of the lobules. So these lobules will become disorganized. The structure is destroyed. So you have lobular disarray, and then you have variable hepatocyte necrosis. And the reason it's called acute hepatitis is because the duration is usually less than 6 months, and in most cases, the hepatitis is self-limited. Therefore, once you remove whatever is causing injury to the liver will go back to normal. For chronic hepatitis, it occurs where you have persistent and progressive inflammation, which leads to injury of the hepatocytes. And histologically, in chronic hepatitis, it is characterized by portal-based chronic inflammation. So when you look histologically at the liver, the inflammation will be centered around the portal area, the area that has the portal vein, the hepatic artery, the branch of the hepatic artery, and the bile ductules. And the reason it is called chronic hepatitis is because you'll have elevated liver enzymes that last more than 6 months. So 6 months is a duration that defines something as being acute or chronic. So this is just a diagrammatic histological segment, and this is to show you inflammation around the portal area. Here, the inflammation has distorted, so you will not be able to see the vascular lumen of a portal vein or a hepatic artery, but this is the portal area. So what causes hepatitis? What is the etiology? So etiology, we said, means causes. So the commonest cause of hepatitis is infections, especially viral infections. And we have what is called viral hepatitis with hepatitis A, hepatitis B, hepatitis C, hepatitis D, and hepatitis E viruses. This viral hepatitis can also be caused by other viruses other than the hepatitis viruses, like, for example, by your cytomegalovirus, your Epstein-Barr virus, your herpes simplex virus. It can also be caused by adenoviruses. Other than that, I think I didn't put it here. It can also be caused by other infections other than viruses, but viruses are the most common causes of hepatitis. And when it is caused by viruses, we call that viral hepatitis. Another cause is autoimmune disorders. So we'll refer to that as autoimmune hepatitis. It can also be drug induced. So you've taken excess drugs or through other mechanisms. So you have drug induced hepatitis. We also have alcoholic hepatitis. So excessive consumption of alcohol can lead to inflammation of the liver, leading to alcoholic hepatitis. Then we have what is called non-alcoholic steatohepatitis. So you have hepatitis that morphologically is similar to alcohol, but it is not caused by alcohol. And this is usually seen, for example, in patients who have diabetes mellitus, patients who have metabolic syndrome, patients who have dyslipidemias. You can go and read about non-alcoholic steatohepatitis. Then hepatitis can also be caused by metabolic causes. These are inherited disorders. For example, your Wilson's disease, your alpha-1 antitrypsin deficiency. We talked about alpha-1 antitrypsin deficiency in emphysema, but it also can cause hepatic injury leading to hepatitis. And then you have hemochromatosis. So how do they cause inflammation? So inflammatory cells along with pro-inflammatory cytokines can cause hepatocyte degeneration and necrosis. This also will then lead to induction of your stellate cell. And once you induce the stellate cell, you promote fibrosis, and this can lead to the formation of liver cirrhosis over time. And this you will learn in detail in subsequent lectures. How does hepatitis present? So in acute hepatitis, most of the time you'll have non-specific constitutional symptoms, like these patients can present with fever, they can present with fatigue, they can present with malaise. And then, of course, because of alteration in bile drainage, they get jaundice. They present with nausea, vomiting, weight loss, and abdominal pain. I mean, the liver is found in the abdomen. And depending on the extent of damage, they might present with signs and symptoms of liver failure. I don't know whether you have, let me see if you have a lecture on liver failure. Yeah, but you can go and read on liver failure. Then for chronic hepatitis, usually patients will present with asymptomatic or non-specific constitutional symptoms. And most of the time, these patients will be diagnosed on laboratory evaluation. So a patient is presenting with non-specific symptoms, you do a laboratory test and you find that the liver enzymes are elevated. Then you probe further, probably find they have a viral infection or they have an autoimmune disease, and this will be non-specific. So in chronic hepatitis, they may present with features of portal hypertension and cirrhosis in later stages. That chronic inflammation with activation of the stellate cell will now lead to the development of liver cirrhosis, which you will learn in your lecture on Wednesday. So how do you diagnose hepatitis? So we usually perform a test called liver function test, LFTs. And in the liver function tests, there are specific enzymes you look for that are produced by liver cells. Remember our lecture on necrosis in the previous semester, and we say that in necrosis, when you have cell death, the contents of the cell are usually spilled out, and some of these contents can be measured in blood. So it's the same as the liver. So the liver cells contain certain enzymes, the transaminases. We have alanine and aspartate transaminases, so that when you have liver injury, these enzymes leak out of the cell and can be measured in blood, and you're going to find that they will be elevated. Then we also have alkaline phosphatase, which is also usually slightly elevated. Alkaline phosphatase is mainly a marker of your biliary system, so that if you have obstruction in the biliary system, you're going to have markedly elevated alkaline phosphatase. Then if you're suspecting that the cause of the hepatitis is a viral infection, then you can do viral serologies. And if the cause is the maybe hepatitis B or hepatitis C virus, they're going to be positive. The viral serologies are going to be positive. If it is an autoimmune hepatitis, then there are specific antibodies that are produced in autoimmune hepatitis, which you will measure, and they will be positive. If the disease is caused by medicine to have elevated urinary copper, your ceruloplasmin is going to be elevated. In alpha-1 antitrypsin deficiency, of course, your alpha-1 antitrypsin levels are going to be low, and these are important in the diagnosis of various causes of the hepatitis. I put this image here to show you, this was a patient in Mama Lucy. So your liver function tests usually have several parameters. We've said one of the functions of the liver is its synthetic capacity, its ability to synthesize certain proteins, and especially albumin. So therefore, when you're ordering for liver function tests, one of the components of the liver function test is usually your protein, your total protein, because it tells you the synthetic capacity of the liver. If you have liver failure, one of the things that will be compromised is the synthetic capacity, and therefore your total protein is usually reduced. We usually refer to the reference ranges, so you can be able to tell whether a value is high or low. Then another component is gamma GT. I will not go into detail, but you can see your transaminases. So ALT is alanine transaminase, and you can see in this case it is elevated. So it is usually should be less than 41. In this patient, the alanine transaminase is 1,199. Also, gamma GT is one of the enzymes also produced within the liver. You can see it's also high. Your alkaline phosphatase, we've also said it will be high. You can see here the patient had an alkaline phosphatase of 520 against the upper limit of 129. You can see the albumin level here is reducing. You can see it's 37. Um, the lower reference range is 39.7. So this is significant, meaning that this patient has liver damage and the synthetic capacity of the liver is starting to be compromised. Then probably this patient presented with jaundice, and jaundice is due to an elevation in your bilirubin levels. And you can see the total bilirubin levels of this patient are 215, which is what, 10 times more than the limit. It should be less than 20. So this is a patient probably who presented with jaundice, you're suspecting liver disease, and therefore you order a liver function test. So this is how it looks like. So once you do a liver function test and you see that the tests are abnormal, then now you go towards finding what is the specific cause of this abnormality. So you want to know, does the patient take alcohol? So it could be alcoholic hepatitis, can give you this. If they're not, maybe it's a child, then you suspect infection, and therefore now you go and do your viral serologies, or you'll suspect metabolic abnormalities, those genetic metabolic abnormalities like your Wilson's disease, your alpha 1 antitrypsin deficiency. So you want to do tests for those specific disorders. So let's look at each one of the causes of hepatitis. We'll start with viral hepatitis. And we said for viral hepatitis, the main are your hepatitis A, hepatitis B, hepatitis C, hepatitis D, and hepatitis E. Though you have other viruses like your cytomegalovirus, your EPV, your herpes simplex virus, your adenovirus, but the main are your hepatotropic viruses, what we call the hepatitis. So they're even given the name hepatitis because of their predilection to hepatocytes. So let's start with hepatitis A. So for your hepatitis A virus, I don't know whether you're taught microbiology, but hepatitis A is a single-stranded RNA virus from the Picorna virus family. So I do I don't know whether you were taught microbiology, but if you were, just a minute. Um, So hepatitis A is a single-stranded RNA virus. So for viruses, they are classified under what is called Baltimore classification. And depending on the genome of the virus can either be an RNA virus or a DNA virus. And hepatitis A is an RNA virus. The thing about it is that it usually causes a benign, self-limited infection, meaning that it will rarely progress to a chronic infection. Once you get it, your body will, the immune system will be able to eradicate it. It's usually transmitted via the fecal oral route. Therefore, you will get it in contaminated food or water. And in our setup, most of the time, it is responsible for the outbreaks that you see in schools. So it is associated with overcrowding or poor sanitation, therefore being associated with outbreaks in institutions, for example, in schools and in nurseries. It can also be contracted from raw or steamed shellfish. It is usually found in children, and in children, you can either have an asymptomatic infection where you have the infection, but you don't show any symptoms, or you can have a symptomatic infection that can occur with or without jaundice. In adults, infection is usually more severe with malaise and jaundice for about 7 to 10 days. And this virus will be shed in stool for 2 to 3 weeks before and 1 week after the onset of jaundice. We've said it's a self-limited infection. So hepatitis A rarely will cause massive hepatic necrosis and acute liver failure, but it can. And this will be fatal in less than 0.5 of the cases of people infected by hepatitis A. The thing about hepatitis A, like I've said, it does not produce chronic disease or carrier state in immunocompetent patients, so you don't carry the virus. And the incubation period of this virus is usually about 2 to 6 weeks. And how you diagnose someone as having hepatitis A infection is that you will measure IgM antibodies against your hepatitis A. So your serum IgM anti-hepatitis A virus antibodies are going to be positive. So fecal shedding of the virus ends as the IgM titers rises, because when the IgM titers rise, it means that fecal shedding of the virus with it will reduce. Once the acute infection has subsided, you do form your IgG antibodies, which will persist for years, and the presence of your IgG antibodies confers lifelong immunity. It means that you are exposed, your body was able to produce antibodies, and these antibodies will protect you from future infection. There is also the hepatitis A virus, which offers protection against infections. In fact, now it's one of the viral vaccines that is given to children as part of the vaccination schedule. So patients who have hepatitis A virus hepatitis, when you take histologic section, what you're going to see is periportal inflammation and necrosis. So you will see necrosis around the portal area and also inflammation. You're going to see what is referred to as ballooning degeneration and also apoptosis of the hepatocytes around the portal area. You can see cholestasis, where you'll have increased portal and periportal plasma cells, and this is usually specific for your hepatitis A. You also see what are called acidophil bodies, or you can also see cytolysis, which is usually present, and this is due to a collapse of the reticulin network, where cells have disappeared with appearance of macrophage aggregates. When you have severe hepatitis, you're going to see bridging necrosis. So bridging necrosis means that it is necrosis that is moving from the portal area to the central vein, from one central vein to another, or from the central vein to the portal area in a different lobule, and that is what we call bridging necrosis. You also see what is called interface hepatitis, and interface hepatitis is where you have inflammatory cells that spill over into adjacent parenchyma to cause necrosis of periportal hepatocytes. So apart from the inflammatory cells that are around the portal area, they're still going to get into the lobule itself, like around the zone 3. So now you're going to see inflammation around that area. Then you'll have relative sparing of your centrilobular hepatocytes because the infection is affecting those that are near the portal area. So this is just a diagrammatic representation of the same. So you have this inflammation. So these dots are inflammation, and this is a portal region, and you can see these inflammatory cells. And then you have interface hepatitis. So you can see these inflammatory cells are moving from the portal area and entering into the parenchyma. And this is seen in hepatitis A infection. Then we have these apoptotic bodies. Remember our lecture on necrosis and apoptosis, and you know one of the things is that your nucleus disintegrates. We have cholestasis. Cholestasis is where you have bile accumulating in the hepatocytes, and you can see they have this color change because of that accumulation. And then you have these pink amorphous substances. These are your acidophil bodies. The other virus is your hepatitis B. And unlike hepatitis A, hepatitis B is a DNA virus. It's actually a partially double-stranded DNA virus from the Hepadna virus family. And once you have an infection with hepatitis B, it has an incubation period of about 2 to 26 weeks. So it can actually be a very long incubation period. So hepatitis B can be transmitted from mother to child. So one of the tests that pregnant women have to do during the prenatal period is usually hepatitis B. You want to establish that the pregnant woman does not have hepatitis B. So because of the likelihood of mother to child transmission. Hepatitis B can also be transmitted via blood transfusion. Hence why even in the lecture in blood transfusion, we talked about hepatitis B being one of the viruses we test for in blood for blood transfusion. So blood screening has reduced this route of infection. It can also be transmitted via unprotected sex. It can be transmitted through sharing of needles, so for intravenous drug users. And it can also be transmitted in children through minor breaks in skin and mucous membranes. So when you have a hepatitis B infection, you have 5 main outcomes. So the patient can either have an acute hepatitis with recovery and clearance of the virus, or you can have non-progressive chronic hepatitis. So they have this elevation in your liver enzymes that is more than 6 months, but it doesn't progress to liver cirrhosis, liver failure, or hepatocellular carcinoma. Or you can have progressive chronic disease that will eventually lead to fibrosis of the liver, giving you cirrhosis. Or this hepatitis B can give you fulminant hepatitis with massive liver necrosis, and this is the worst form of hepatitis B virus infection, and this is what will lead to liver failure. Or a person who has hepatitis B infection can be an asymptomatic healthy carrier. So a carrier is someone who's not showing symptoms, but they do have the virus. And this carrier state, you find 75% of people in Asia and 75% of carriers live in Asia and in the Western Pacific Rim, since these are the areas with very high levels of hepatitis B infection. So when you have hepatitis B infection, it confers a lifelong risk of hepatocellular carcinoma in 40% of men and 15% of women. So those who are infected, 40% of the men are likely to develop hepatocellular carcinoma, and 15% of the women are also likely to develop hepatocellular carcinoma. But unlike hepatitis A, hepatitis B remains in blood during active episodes of acute and chronic hepatitis. In hepatitis A, we said it's a self-limited infection and therefore your immune system is able to clear it. But for hepatitis B, it remains in blood during active and chronic inflammatory states. So how do you diagnose a patient as having hepatitis B? We do viral serology. So, viral serology in hepatitis B is usually detectable 1 to 12 weeks after initial infections, with primary viral marker being the hepatitis B surface antigen. So, these viruses produce specific proteins as they are replicating and infecting cells. And for hepatitis B, one of them is the surface antigen, which you can measure in blood. So the presence of the hepatitis B surface antigen rarely persists beyond 6 months after infection. And once you see it, it will typically precede detectable quantities of the corresponding antibody to the surface antigen. So you'll find your body, once exposed to the surface antigen, it will form antibodies against it. So you'll have surface antigen first, and then after that, you have antibodies to the surface antigen. So immune mediated destruction of your nucleocapsid, which is one of the proteins in the virus, allows for exposure of what is called a core antigen and an E antigen with subsequent antibody development. So once you expose the core antigen, your body forms antibodies against the core antigen. If you expose the E antigen, your body forms antibodies against the E antigens, and all these can be measured. And then, since this is causing a hepatitis with destruction of hepatocytes, you'll also have liver enzymes that will be elevated, your ALT and your AST. So the presence of antibodies to your surface antigens usually indicates an immunized status, and this is the basis of your hepatitis B vaccine. Most of your vaccines are filled. So once you're vaccinated, you form antibodies against the surface antigen, and this is usually the marker of immunity against hepatitis B. You can have seroconversion, which refers to the transition between an acute immune active phase to an inactive carrier state, and this will be marked by the spontaneous development of antibodies to your hepatitis B E antigen. So your hepatitis B E antigen and your hepatitis B DNA appear in serum soon after your hepatitis surface antigen, and they will signify ongoing viral replication, so that when you have persistence of your hepatitis B E antigen, it is usually an indicator of progression to chronic hepatitis. We say that the surface antigen rarely persists beyond 6 months, which we said is the cutoff between calling your hepatitis acute or chronic. So when the levels of hepatitis surface antigen have gone down, but the levels of your hepatitis E antigens go up, it means that this patient is now moving towards chronic hepatitis. So this is just a summarization of this. So we have your hepatitis surface antigen, we have antibodies against the core antigen, and antibodies against the surface antigen. So in chronic infection, you expect the antigen to be there. the antibodies against your antigens to be positive, but antibodies against the surface antigen will usually be negative. In someone who has recovered, we said that the surface antigen will rarely go beyond 6 months, so you expect that to be negative. But of course, there are those antibodies that will form. So antibodies against the core antigen and the surface antigen are going to be positive. So that now eventually, for those who have been immunized, you've been given the hepatitis B vaccine. Of course, you don't have the surface antigen, you are not infected, so you don't have the hepatitis core antigen, therefore you don't have antibodies against it, but you are given the vaccine mimics the surface antigen, and therefore you're going to form antibodies against the surface antigen, and you expect this patient to have positive antibodies to it. And someone who's never infected and someone who has never been immunized, of course, you expect all this to be negative. Microscopically, when you have an acute hepatitis, of course, we talked about lobular disarray, that arrangement of the liver into lobules is distorted. You get ballooning degeneration because of accumulation of substances within the hepatocytes. You have multiple apoptotic bodies, you have Kupffer cell activation, and you have lymphocyte predominant lobular and portal inflammation. In chronic hepatitis B infection, you have lymphocyte predominant portal inflammation with interface hepatitis, and then you'll also have spotty lobular inflammation. And you can see in hepatitis, majority of the inflammation is around the portal region. So this is just a histologic segment to, you can see the difference between what is on your right and on your left. So on your right, you can see the hepatocytes, but here the hepatocytes have sort of clearing within the cytoplasm, and this is what we call ballooning degeneration, which is very common, and then they cause this to appear like ground glass appearance, like when you break glass, and then the way it appears, it's like it has particles. That is characteristic of hepatitis B infection. Then the image on your right is just to demonstrate that this is a portal region, and you have inflammation in that region. So we've said when you have hepatitis infection, hepatitis B, the outcomes will depend. So when you have an acute infection, 65% of the patients are going to have subclinical disease. That is, they will most likely not even show any symptoms, and 100% of this will recover. Then 25% will have acute hepatitis. Of the acute hepatitis, 9%, 99% recover, and then 1% of this acute hepatitis gives you fulminant hepatitis, where you have liver failure with extensive liver necrosis, and these are patients who will either die or their liver failure is so extensive that this is a patient that will require liver transplant. Then there's also another 5 to 10% will now progress to chronic hepatitis. Then there are those who can recover. Then others will have progressive. Remember, we said there's non-progressive chronic hepatitis. Then there's chronic hepatitis that is progressive, that will go into cirrhosis. And some others will then go into hepatocellular carcinoma, and this also require a transplant, or they will die of liver failure. The other hepatitis virus is a hepatitis C virus. So hepatitis C virus is also an RNA virus, a single-stranded RNA virus from the Flaviviridae family, and it has an incubation period of about 4 to 26 weeks. Hepatitis C is also transmitted parenterally, meaning you can get it from blood transfusion or intravenous drug use. It can be transmitted in the perinatal period, so mother to child, or you can get it via sexual intercourse, with the most common mode being sharing of contaminated needles among IV drug users, the parental transmission. We've also said blood transfusion and also organ transplant. If someone transplants an organ that's from a patient with hepatitis C, then you can transplant the hepatitis C to the patient. Unlike hepatitis B, which has many eventualities, for hepatitis C, once you get an infection, 50 to 80% of the patients who get hepatitis C develop chronic liver disease, with 20% of this developing cirrhosis. You can see for hepatitis B, majority, about 90%, they'll just have an acute infection, and then about 5 to 10% will get chronic hepatitis. But for hepatitis C, 50 to 80% will develop chronic liver disease. And with this, there's a high risk for hepatocellular carcinoma, particularly in patients who are alcoholics and they have hepatitis C infection. So 57% of these patients in 10 years will develop hepatocellular carcinoma. These patients with hepatitis C virus infections, they can also have acute liver failure, though this is usually rare. So hepatitis C vaccine, hepatitis C, why it's important is that since it's an RNA virus, means that once it infects the cell, it is translated to the proteins. If you remember from your biochemistry, if you have DNA has to be translated to RNA and then the RNA to form proteins. But when you have a virus that is already an RNA, it just means it will just be translated to the proteins. So the viral RNA usually encodes a single polyprotein that is processed by several proteases into 10 functional proteins. And the proteins that are important for hepatitis C to propagate its effects in hepatocytes are: one, your viral protease, which is usually needed for complete processing of the polyprotein; the NS5A, which is usually essential for assembly of your hepatitis C virus into mature virions within the cell; and then the viral RNA polymerase, which is usually important for replication. So these proteins have hepatitis C infections. So you want to give them drugs that will stop the viral protease, that will stop the NS5A, and will also stop the viral RNA polymerase, and eventually stop the hepatitis C virus replication within the cell. So the goal of treatment is usually to eradicate the hepatitis C RNA, which is defined by the absence of detectable hepatitis C RNA in blood 6 months after treatment is stopped, and is associated with a high probability of cure. You can actually be cured from hepatitis C. So currently, over 95% of your hepatitis C virus infections are curable. So how do you diagnose someone as having hepatitis C? You have to demonstrate the hepatitis C RNA, which is usually detectable in blood for 1 to 3 weeks. And it is usually coincident with elevations in serum transaminases. So a patient has come, probably has jaundice, you've done the liver function test, the transaminases are elevated, then you do the viral serologies and you find that the hepatitis C virus RNA is elevated. In symptomatic acute hepatitis C virus infection, hepatitis C virus antibodies are detected in only 50 to 70% of the patients. In the remaining patients, the anti-HCV antibodies will emerge after 3 to 6 weeks. Therefore, um, when you want to confirm that a patient has hepatitis C, we prefer using hepatitis C virus RNA as opposed to using antibodies. So testing for hepatitis C RNA must be done to confirm the diagnosis of chronic hepatitis C infection. You don't do antibodies, like we said. Some patients will not have detectable levels. So anyone with detectable serum hepatitis C RNA needs treatment and long-term medical follow-up. So a characteristic clinical feature of patients who get the chronic hepatitis C infection is they will have episodic elevations in serum aminotransferases separated by periods of normal or near normal enzyme levels. So it is episodic. The other hepatitis virus is hepatitis D virus, also called Delta virus. And this is also an RNA virus that is dependent for its life cycle on hepatitis B. So you cannot be infected with hepatitis D by itself. There has to be hepatitis B infection. And infections arises so you can be infected together. So co-infection with hepatitis B, which provides the surface antigen that is necessary for production of complete hepatitis D virus virions. And when you have a co-infection with hepatitis B, these are patients who will have severe acute hepatitis. These are patients who are predisposed to getting fulminant liver failure. And these are also patients who are predisposed to progression to chronic infections. Another thing is you can have a super infection. So the patient already had hepatitis B, like those who are chronic hepatitis B carriers, and then they get a super infection with hepatitis D virus infection. How do you diagnose hepatitis D RNA? You can demonstrate it in serum, or you can look for IgM antibodies against the hepatitis D, and this is usually a reliable indicator of recent hepatitis D exposure. In cases of co-infection, where you have hepatitis D and hepatitis B, you will find the presence of IgM antibodies against the hepatitis D, and then also you will look for the core antigens against the hepatitis B. So you want to measure both to show you that this is a co-infection. Where you have a super infection, you're going to see your hepatitis B surface antigen in serum and anti-hepatitis D antibodies, either IgG or IgM, to show you that these are exposure to hepatitis D. So because hepatitis D is reliant on hepatitis B for its survival, so vaccination against hepatitis B on itself now confers protection against hepatitis D, which is dependent on hepatitis B for its survival. The last hepatitis virus is your hepatitis E virus, which has an incubation period of 4 to 5 weeks. This is also an RNA virus. So most hepatitis viruses are RNA viruses, with the exception of hepatitis B, which is a DNA virus. So hepatitis is a waterborne infection, and it also produces a self-limiting disease. It's considered as zoonotic infection since there are reservoirs of this virus in monkeys, cats, pigs, and in dogs. The most important thing about hepatitis E is that it can cause high mortality amongst pregnant women, and this has been found especially in India. And like hepatitis A, it is not associated with chronic liver disease. So the three hepatitis viruses are B, C, and D, which can give you chronic liver disease. For hepatitis A and hepatitis E, those give you self-limiting infections. How do you diagnose them? So before the onset of clinical illness, your hepatitis E virus RNA and the virions can be detected by PCR in stool and also in serum. The onset of rising serum transferases, clinical illness, and elevated IgM anti-HEV titers will virtually be simultaneous. So they'll occur together. So you will see a rise in your serum aminotransferases. You'll see an elevation in your IgM antibodies against your hepatitis E virus, and then this patient will present with clinical illness. Like, for example, they're going to have jaundice, the malaise, all the symptoms that we talked about at the beginning. So in patients who have hepatitis E virus infections, the symptoms usually will resolve in 2 to 4 weeks, during which the IgM titers will fall and they will be replaced by IgG titers. So when you see IgG titers, it just shows that that patient was infected by hepatitis E and that infection has now resolved. Sorry, this is a busy table, but it just shows you the clinical syndromes that you expect in hepatitis virus infections. We say that some of them can give you asymptomatic or subclinical infections where they don't have any jaundice, or they can have mild non-specific symptoms or no symptoms at all. And how you'll know that they were infected is that you do a liver function test and see incidental elevations in some of their enzymes. And this is commonly seen in patients who have hepatitis A, hepatitis B, and hepatitis C infections. Then you can also have an acute symptomatic illness. Of course, since it is symptomatic, they are going to present with jaundice. They're also going to present with non-specific symptoms like nausea, malaise, right upper quadrant pain, and this is commonly seen in hepatitis A, hepatitis B, hepatitis E, and sometimes hepatitis C. You can also get acute liver failure, and the liver failure is because they get what is called hepatic encephalopathy due to accumulation of ammonia products, which will affect the brain. The liver is also involved in the synthesis of coagulation factors, so they get coagulopathy. These patients present with severe jaundice, and of course, death from acute liver failure is usually very high, and this will be seen in hepatitis B. Especially where there's a co-infection with hepatitis D. This will be seen in hepatitis E, especially in pregnant patients, and then rarely this will also be seen in hepatitis C. Then chronic hepatitis, of course, they'll have those chronic symptoms, mild jaundice, and they'll have persistent elevations in your liver enzymes. These are more than 6 months. And this will be seen in hepatitis B, hepatitis superinfection with hepatitis D. You can also have a carrier state. So the patient has the virus, but they are asymptomatic. And the carrier state, the problem is that they are able to transmit. They can transmit this virus to other people, and this is usually seen more in hepatitis B than in hepatitis C infections. Then this chronic hepatitis can progress to cirrhosis, which will present with portal hypertension, ascites, varices, and encephalopathy. You will see this in the next lecture. This is common in patients who have hepatitis B and hepatitis C infection. You can also have hepatocellular carcinoma, common in hepatitis B and hepatitis C. And you can also have extrahepatic manifestations. This is commonly seen in hepatitis C. So they can have vasculitis, arthritis, cryoglobulinemia. They can even have renal disease, and this is commonly seen in hepatitis C. In fact, when you talk about post-infectious glomerulonephritis, one of the things you're going to mention is hepatitis B or hepatitis C infections that can give you renal disease. And then, of course, this summarizes the specific things that you will see histologically. We've mentioned in acute hepatitis, you're going to see lobular disarray, you're going to see necrosis, you're going to see inflammation, especially in the portal region. You also have spillage into the parenchyma, the interface hepatitis. Then, with progressive chronic hepatitis, you'll have fibrosis, therefore, you'll have cirrhosis, and then also this cirrhosis can lead to cancer, and you get hepatocellular carcinoma. So, these are the key pathologic changes that you see in hepatitis A. So in hepatitis B, characteristically, that ballooning degeneration, you see these ground glass hepatocytes. And this is just this, you can see the hepatocytes here. Yeah, they're enlarged, and you can see these substances within the cytoplasm. And then this is just an immunohistochemical marker to show you that these cells are infected by hepatitis B. So this is usually characteristic. So the way these hepatocytes look is characteristic when someone has hepatitis B virus infection. Of course, this is the portal inflammation. You can barely see the lumen of the portal vein, the hepatic artery, or I think this is the ductule, the bile ductule. Yeah, but you can see these places basically consumed by inflammation, and then this inflammation is spilling into the parenchyma. Then you can have non-viral infections, which can be bacterial, parasitic, or fungal. And these infections can reach the liver via several mechanisms. So one, it can be ascending infection. So this infection is coming from the gut or the biliary tract, and it ascends into the liver. For example, ascending cholangitis, where you have infections within the biliary tract that climb up to the liver, or from the gut they go through the portal vein and reach the liver. Then you can have vascular seeding, most often through the portal system via the gastrointestinal tract. You can have direct invasion from an adjacent source. So you can have an organ next to the liver with an infection, and then that infection moves to the liver. Or you can have penetrating injuries. For example, if someone stabs you with a knife and the knife is dirty, it has bacteria, or you're involved in an accident and there are substances within the car that stab you and stab the liver and introduce bacteria. So penetrating injury can cause infections. So for your bacterial infections, this lead to liver abscesses, and the commonest infections implicated in this are, for example, your E. coli, your Klebsiella, your Staph aureus, your Streptococci, and some of the anaerobes. And of course, these patients are going to present with fever, right upper quadrant pain, the liver is going to be enlarged, hepatomegaly, and they might also have features of sepsis. And when you take or you remove the abscess, of course, you're going to see pus-filled cavity. It will have neutrophils, necrotic debris, and granulation tissue. They can also have infections by Staphylococcus, Salmonella typhi. You can have infections by Leptospira interrogans. You can have infections by Mycobacterium tuberculosis. And of course, with Mycobacterium tuberculosis, you're going to have a granulomatous inflammation. But here in the liver, it's mostly going to be small granulomas that are usually non-cacheating. For parasitic infections, the most common parasite to be implicated is your Entamoeba histolytica, which causes amoebic liver abscesses. You can have infections by Echinococcus granulosus, which gives you hydatid disease. And in hydatid disease, they usually have cysts within the liver with laminated membrane with daughter cysts daughter cysts and fibrous host capsule as a reaction to the cyst. So your immune system is going to form a capsule to protect the cyst. Common in our setup is schistosoma mansoni, and schistosoma japonicum, especially in Ukambani. We see a lot of schistosomiasis that affects the hepatobiliary system, and these are patients who are going to present with hepatosplenomegaly and portal hypertension. And schistosoma usually results in a granulomatous inflammation around the eggs of these parasites. This will be seen in the portal tracts, and it causes what is called periportal or pipe stem fibrosis. We also have malaria, of course, one of the stages of malaria, the the parasitic cycle of malaria. One of the stages is your hepatic stage. It has a red cell stage, but it also has a hepatic stage. And here it causes massive necrosis of your hepatocytes, and it can give you hepatosplenomegaly. You can also have toxoplasmosis. This is seen in patients who have HIV, and this causes focal necrotizing hepatitis. And patients are also going to present with mixed inflammatory infiltrate. We also said another cause of hepatitis is autoimmune hepatitis. So autoimmune hepatitis is a chronic progressive hepatitis of unknown cause, and it is usually characterized by continuing hepatocellular inflammation and necrosis tending to progress to cirrhosis. So most of the patients with autoimmune hepatitis are going to get liver cirrhosis. So the proposed pathogenesis of autoimmune hepatitis involves the combination of genetic predisposition and environmental triggers. So for genetic predisposition, it may relate to several defects in immunologic control of autoreactivity. I think we went through autoimmunity in our general pathology and immunology lectures, and how you eventually develop autoimmune disease. So if you have defects that prevent autoimmunity, then you're going to develop autoimmune disease. And we say that this is usually associated with certain HLA haplotypes. For example, your DR3, your DR4, your B8, and your B14. Then, of course, we said for you to get an autoimmune disease, it is an interplay between two factors: genetic predisposition and an environmental trigger. So the agent that will trigger your autoimmune response against your liver antigens could be infections, radiation, or other chemicals. So this cause a necro-inflammatory liver damage and then cirrhosis if left untreated. So one of the environmental triggers are the viruses that we have talked about, especially in someone who has a genetic predisposition to autoimmune disease. One of the features of autoimmune hepatitis is that you're going to find it mainly in females. So 70% of the patients are going to be female. It will be autoimmune because you're going to do your liver function tests and find the liver function tests are deranged. Then you do the serologic evidence of viral infections, like all I've talked about, and they'll be negative because the cause is not a viral infection. So there'll be absence of serologic evidence of viral infection. Then you'll have elevated serum IgG levels. These patients also have high levels of autoantibodies in 80% of the cases. And you'll also have, in these patients, they also have other forms of autoimmune disease. So they're not only presenting with the autoimmune hepatitis, they also have other autoimmune diseases, especially in 60% of the patients. They might be patients who are on treatment for rheumatoid arthritis, or they're on treatment for thyroiditis, maybe Hashimoto's or Graves'. They have Sjögren's syndrome or ulcerative colitis, but they're also presenting with autoimmune hepatitis. So autoimmune hepatitis is classified into two types, and this is usually based on the pattern of circulating antibodies. So we have type 1, which is usually more common in the middle age and older individuals, and it is usually characterized by the presence of specific antibodies. For example, your anti-nuclear antibody, your anti-smooth muscle-acting antibody, your anti-mitochondrial antibody, your anti-soluble liver antigen, stroke liver pancreas antigen antibodies. Then we have type 2, which is usually seen in children and teenagers, and it is characterized by the presence of anti-liver kidney microsome 1 antibodies and anti-liver cytosol 1 antibodies. So when you have a patient presenting with jaundice, then you've done your liver function tests, they're deranged. You've done your viral serologies, they're negative. Then you suspect that the patient, you've looked for other causes, there is none, then you suspect that the patient has autoimmune hepatitis. Therefore, you have to now move into looking for some of these antibodies in circulation to confirm your diagnosis. So for autoimmune hepatitis, it shares patterns of injury with acute and chronic viral hepatitis, like I've discussed, that lobular disarray, your periportal inflammation. So for viral hepatitis, however, fibrosis will typically follow many years of slowly accumulating parenchymal injury. But in autoimmune hepatitis, there will be an early phase of severe parenchymal destruction followed rapidly by scarring. So a patient who has autoimmune hepatitis will progress to fibrosis and cirrhosis faster than a patient who has viral hepatitis. So that's what it means. When you look histologically, important features is you're going to see necrosis and inflammation. This will be indicated by extensive interface hepatitis with foci of confluence. So you'll see perivenular and bridging necrosis. And because there's necrosis, if it is extensive, you're going to see parenchymal collapse. That inflammation that you see is going to be predominated by plasma cells. And then they also form what are called hepatocyte rosette, which is a form of liver cell regeneration developing in isolated surviving hepatocytes or small groups of hepatocytes within an area of collapse. So you have a large area of necrosis, but within that, there's a group of cells that are viable and are proliferating. So that's called the hepatocyte rosette. These patients will present with non-specific symptoms. So they have fatigue, they have upper abdominal discomfort, they have anorexia. Since there's hepatitis, they have jaundice, they have enlargement of the liver, hepatomegaly, and in severe disease, they get encephalopathy, especially if the inflammation is extensive, leading to liver failure. So mortality for patients with severe untreated autoimmune hepatitis is approximately 40% within 6 months of diagnosis. So you can see a lot of them die. For those that survive, cirrhosis will develop in at least 40%. Immunosuppressive therapy is usually effective, leading to remission in 80% of the patients and enabling long-term survival. Where you have liver failure, then these patients will require liver transplantation. The other cause of hepatitis is drugs or toxin-induced liver damage. So we know that the liver is a major drug metabolizing and detoxifying organ in the body. And as a result, it is subject to injury from an enormous array of therapeutic and environmental chemicals. So this injury to the cells can either be due to direct toxicity, so whatever you've consumed is directly toxic to the hepatocytes, or it could be due to hepatic conversion of that xenobiotic product to an active toxin. So whatever it was inactive, but now the liver has converted it into a substance that is hepatotoxic. Or it could be due to immune mechanisms, such as by the drug or the metabolite acting as a hapten to convert a cellular protein into an immunogen. So whatever you have consumed now triggers an immune response. So that inflammatory response is what will damage your liver, leading to hepatitis. So exposure to a toxin or therapeutic agent should always be included in the differential diagnosis of any form of liver disease. So if you've ruled out alcohol, for example, you want to know, has the patient taken any drug, or are they taking any drug that can lead to the hepatitis? So these drug reactions can be predictable or unpredictable. So for the predictable reactions, this will affect all individuals in a dose-dependent fashion. For example, the dose of paracetamol is 1 gram 3 times a day for whatever duration it is. Therefore, for someone who consumes 6 grams or 10 grams at once, of course, there's going to be an effect, and that's what we call a predictable response. For the unpredictable reactions, they will depend on the idiosyncrasies of the host, particularly the propensity to mount an immune response to the antigenic stimuli, or the rate at which the agent can be metabolized. Of course, in autoimmune disease, we talk about genetic predisposition, so that how you react to a certain drug, how your enzymes within the liver react to a certain drug is different from one person to the other. So that is the unpredictability. So that you might not know that you're allergic or a certain drug will give you an effect until you take it. So among hepatotoxic drugs, paracetamol, acetaminophen is what is most often studied. However, there is a broad range of different pharmacologic agents that can induce liver damage. For example, some of the anesthetic drugs that we use, anti-cancer drugs, antibiotics, anti-TB drugs, antiretroviral drugs, cardiac medications. Also, there's a plethora of traditional medical therapies and herbal remedies that have been hepatotoxic. And of course, in our setup, we have a lot of patients suffering from hepatic damage due to these traditional medical therapies or the herbal medicine. Also, one of the things that you are going to encounter a lot in your clinical practice is the anti-tuberculosis drugs and antiretroviral drugs. Like, for example, for a patient who's on treatment for HIV and they're on certain drugs, there's certain anti-TB drugs they cannot be given, because if you give them those drugs, then they're going to develop hepatic injury. So these are some of the things that you are going to encounter in your clinical practice. So drugs may cause hepatitis, characterized by hepatocyte necrosis, and this will be associated with a poor prognosis. They're going to have very elevated aspartate transaminases and alanine transaminases. Also, you can have drugs that will result in abnormal biliary secretion, and these patients are going to have elevated alanine phosphatase. And of course, you've heard of people who've tried to kill themselves by taking paracetamol. And one of the things is the hepatic damage that will be caused. So let's look at acetaminophen-induced hepatitis. So acetaminophen, also known as paracetamol, and N-acetyl-P-aminophenol is one of the most commonly used analgesic and antipyretic drug, either as a standalone medication or combined with other medication. So it can either be given to you as a prescription or over the counter. Most of us buy them over the counter. So normally less than 10% of your acetaminophen is metabolized by the cytochrome P450 system in the liver to generate the N-acetyl-P-benzoquinone imine, the NAPQI. And this NAPQI is then quickly metabolized to a non-toxic metabolite by glutathione. Okay, so this NAPQI may accumulate secondary to acetaminophen overdose. So you've taken more drug, more acetaminophen, so therefore you've generated more of the NAPQI, or due to upregulation of the cytochrome P450 system through chronic use, like for people who are alcoholic, isoniazid during rifampicin. Those who are on treatment for convulsion, e.g. with phenobarbital, they usually have an upregulated cytochrome P450, which means that when you consume paracetamol, it is quickly metabolized to give you the NAPQI. Or for patients who have depletion of your glutathione, because glutathione is important to convert this NAPQI to an inactive metabolite. And this can occur in patients who have malnutrition or in chronic liver disease. And this, when you have accumulation of this NAPQI, it will lead to hepatotoxicity through mitochondrial dysfunction and also cell death. And it is one of the causes of acute liver failure. You've heard of people trying to commit suicide by taking paracetamol. So the treatment of this is usually to give them activated charcoal to absorb what has been consumed, or you give them then N-acetylcysteine, which then binds to this NAPQI and it is excreted from the body. So we've said that hepatotoxicity from drugs, it can either be it's direct or this drug has been converted to something else, for example, the paracetamol, or it can be immune mediated. So for immune mediated injury, we have bioactive drug metabolites that will bind to cellular proteins, and these are exposed to the major histocompatibility complex molecules on antigen presenting cells. And this interaction will trigger an immune response directed against the hepatocyte. One of the drugs that is commonly implicated in this is halothane, which is used as an anesthetic agent. So halothane usually triggers the generation of antibodies that are usually directed against the cytochrome P450 CYP2E1. And in this case, identifying drug-induced antibodies in patients' blood may help in the diagnosis. So apart from antibody-mediated cell death, you have locally released cytokines and reactive oxygen species that will also enhance the hepatic injury. So the drugs will bind to proteins in the hepatocytes. This will make these hapten protein complexes appear as foreign, and your body will then mount an immune response against them. In this case, it is the hepatocytes, leading to hepatic injury. The last cause of hepatitis I'm going to discuss is alcoholic hepatitis. And alcoholic hepatitis is caused by the toxic byproducts of ethanol. So in the body, ethanol is usually metabolized into acetaldehyde, which is a major metabolite of ethanol. And what acetaldehyde does is that it induces lipid peroxidation and acetaldehyde protein adduct formation, which may disrupt cytoskeleton and membrane function of the hepatocyte. Alcohol is also directly toxic to the hepatocyte, as it affects mitochondrial function and also affects membrane fluidity. You can also have reactive oxygen species that are generated during oxidation of ethanol by the microsomal ethanol oxidizing system, which will react with and damage membranes and proteins. So these reactive oxygen species can also be produced by neutrophils, which will infiltrate area of hepatocyte necrosis. So the alcohol and the acetaldehyde can cause cell death, cell death by necrosis, which will cause inflammation and attract neutrophils. And these neutrophils will also release reactive oxygen species, which will make the damage worse. So generation of the acetaldehyde and free radicals is usually maximal in the centrilobular region, making this region the most susceptible to toxic injury. For the other types of hepatitis, especially like for viral hepatitis, we've talked about the periportal region being the most susceptible. But in alcoholic hepatitis, the centrilobular region is what is usually most susceptible to toxic injury. So pericellular and sinusoidal fibrosis will therefore develop fast in this area of the lobule. So if you have an alcoholic who has viral hepatitis, especially hepatitis C, this will accelerate liver disease. So they are likely to get liver disease. And for unknown reasons, cirrhosis develops in only a small fraction of chronic alcoholics. So not every chronic alcoholic will develop liver cirrhosis, but some of them will develop and others will not. So with complete abstinence, at least partial regression of scarring occurs, and the micronodular liver transforms through parenchymal regeneration into a macronodular cirrhotic liver. How do patients with alcoholic hepatitis present? This hepatitis may develop within weeks or months of alcohol abuse, and patients will present with non-specific symptoms, malaise, anorexia. These are patients who present with weight loss, upper abdominal discomfort. They have tender hepatomegaly. They also present with fever, and then eventually some of them will develop alcoholic cirrhosis, which occurs within 15 to 20 years of excessive drinking. They also have what is called steatohepatitis, which because of alcohol, they have accumulation of lipid products within the cytoplasm. Remember, I have said that acetaldehyde induces lipid peroxidation. So you end up having accumulation of these lipids within the cell, what we call steatosis, and this steatosis can lead to hepatitis. So in these patients, they will have hepatocyte ballooning, which will be prominent in the centrilobular region. They have what are called Mallory-Denk bodies, which are eosinophilic cytoplasmic inclusions in degenerating hepatocytes. And unlike, for example, your autoimmune hepatitis, which we said you have a plasma cell-rich inflammation, in steatohepatitis, you have a neutrophil infiltration into the centrilobular region. So this is a hepatocyte, of course, showing you the ballooning degeneration here. And then you have this eosinophilic amorphous structures called your Mallory-Denk bodies. I think that's my last slide. Any question? Someone asked if the exam outline is the same as Patho 2. Yes, it is. Yeah, MCQs, short answer questions, and one long essay question. The cut is usually short, 20 MCQs, 2 short answer questions, and one long essay question. If there's no question, I'll assume this is well understood. Enjoy the rest of your day.